Gorja. Good evening. We're delighted to welcome you all to the Royal Irish Academy for tonight's discourse, Resilience Lessons Learned. This is the final discourse in our 2025-26 series, which examined resilience from various perspectives with distinguished speakers who are experts in their various fields. My name is Daniel Carey. I'm president of the Royal Irish Academy. I also want to welcome our executive director, Lynn Scarf, who's here at the front, treasurer Mary Kelly, also here at the front, Linda Hogan, MRIA, who oversees the management of the Discourse Series as secretary of the Academy. The Academy discourses, Great. The Academy discourses are the oldest, and dare I say, the most renowned series of talks in Ireland. The first discourses were presented in 1786. Historically, they were the occasion reserved for the most distinguished academics to first reveal and discuss their work in public. We now record the discourses and they are available on the Academy's website. I encourage you to have a look. Before we begin, we have a little bit of Academy business to conduct. Our last discourse was entitled The Neuroscience of Resilience, Building Brains to Withstand Life. It took place on the 14th of April, 2026, and minutes were posted online. Since our members did not inform us of any issues with these minutes, I will take them as approved, and I will sign the minute book after this discourse concludes. Welcome to our esteemed speakers for this evening's discourse. Professor Tony Holohan is director of the UCD Centre for One Health, an adjunct full professor at University College Dublin. He previously served as Ireland's chief medical officer and over many years in public service worked across some of the country's most important health challenges. At UCD, he now leads work focused on One Health as a practical way of connecting research, education, policy, and public engagement. In 2024, the center was designated a WHO Collaborating Center for One Health, the first such center in the WHO European region. Áine Lawlor is an Irish broadcaster working for RTE. She hosts The Week in Politics on RT1 television and continues to contribute to various news and current affairs programs following her departure from Morning Ireland in late 2025. Áine has worked on The Pat Kenny Show, Today at 5, RTE 2 FM News, and a variety of television programs, including The Nature of Things, Tuesday File, and as narrator for the highly acclaimed series of clerical sexual abuse in Irish institution, States of Fear. We have a rapporteur for these events, and our rapporteur for tonight's discourse is Professor Steve Kerrigan. He's the member of the Royal Irish Academy's Life and Health Sciences Committee, and he's going to prepare a short summary, a report based on tonight's discourse, which will be published as a blog on our website. So finally, to the discourse itself, Áine, over to you.
Right, I'm looking forward to this. Good evening, everybody. So I'd have done a lot of interviews with you through COVID. But what I'm really glad of tonight is a chance to look back and maybe talk in a wider way, because obviously there was a very different context then. Now, I know there's a government evaluation ongoing and you don't want to cut across that. But I'm wondering, maybe we'll begin if you give me your own thoughts and conclusions since on that time. Are they fully formed yet? What are your takeaways at this stage?
Thanks very much indeed, Áine. And yes, we did meet each other on a number of occasions, not always in person, over the airwaves, one way or another. No, they're not fully formed, I think, and I think probably I reflect probably most individuals in society generally. Ireland isn't the only country that's still kind of processing, in a way, the implications, direct and indirect, from health and from a wider economic point of view. But just for myself, some of the kinds of reflections that I might think about when I think about the disease itself. So we know technically that it's true to say that SARS-CoV-2, which is the name of the virus, caused the disease that we call COVID-19. But the impact that it had in terms of morbidity and mortality was actually shaped by inequality and vulnerability. And it was people who were at the margins of societies in every country in the world, including those most marginalized countries who had the greatest burden to carry. And that's a lesson that I think we have to learn. and it's not just an Irish lesson, by the way. If we're to truly build resilience into our future capacity to respond to shocks of whatever kind, whether those are public health, whether they're economic, whether they're informational, whether they're crises of trust, or whatever they may be, to anticipate that those who will bear the burden to the greatest extent of all of these will be, in effect, the same types of people, marginalized for one reason or another in terms of inequality. And I think if we're to truly think about what resilient means societally, as a society, we cannot call ourselves resilient unless we deal with some of those underlying vulnerabilities that we've now seen and they've been laid bare. And we can talk in terms of the detail perhaps, but people will remember the kinds of vulnerabilities that I'm talking about. So people who lived in the most difficult circumstances, either in terms of where they lived, where they worked, the nature and safety of the work that they did, vulnerability by way of age and underlying illness, and then people who were from certain ethnic backgrounds and so on. And you get into then other layers in terms of the extent to which people were connected into information and in societies. And as I say, that point that I'm making, it's a generic point, generic insofar as it doesn't just apply to Ireland. And that's a lesson that I think has to be learned. Another thing that I take away from it very substantially is that, I think forks in the road for moments. So we made an enormous scientific breakthrough generated by what I'll maybe come back and describe on a couple of occasions, what I would call sort of deep vertical expertise that we have in science, which is wonderful. To find ourselves in a situation where we're using a vaccine within 12 calendar months against a disease that hadn't been known up until that point. And that's a wonderful achievement for which science should be proud. But when it came to implementation of that knowledge, the fork in the road was that we didn't go the right direction and was making those vaccines available to the people who needed them most. When push came to shove, in a sense, we looked after ourselves. Those people who could have access sought and secured access to themselves first, irrespective of vulnerability. And that was a clear lesson, I think, that the world needs to learn. And I know you want to come in with another question, but when I think in terms of the world and the global response, there are many, many reasons why you could express concern about how well we're applying those lessons. And you can look at them in all sorts of different places, look for them in different places. But the challenge that came in negotiating and agreeing what is now the WHO Pandemic Treaty and how that has been effectively watered down by interests of one kind or another, visible in the form of political, invisible in the form of commercial influence, is something that I think should concern all right-minded people.
Okay. And we'll break a lot of that down, I hope, in the next while. But I want to start with, because we'll talk maybe about personal, social, and if you like, state and global resilience. But just in terms of the personal, because you were on the front line of the COVID response in terms of your work every day, but your family was also going through being on the front line of COVID because of your late wife's illness at the time. And looking back, and again, we talk about it very little, but the resilience that your family had to show, so many families had to show, the resilience of people who were sick at that time and had to cope not just with their illness, but also with isolation and without the supports you would normally have, people having to say goodbye in empty churches, all of that. Isn't it remarkable, the resilience that people can just draw on in daily life? Is that one of the things that surprised you through all of this?
Yes, I think so. Societally and at individual levels and within communities, I sometimes think we find the best of ourselves individually and collectively when we find ourselves faced with challenges. And sometimes it's not about necessarily the application of certain, special powers, but the ordinary human resilience that comes with kind of routine and the need to get on with it. In a way, when I think about resilience, I think we can define it in all sorts of different ways, but it is about that ability to simply get on with things and maintain a functioning in spite of the existence of whatever the issue might be that's at issue. And so at a personal level, I think people found great, and many people will have said, and I would say the same thing, you find within yourself reserves to deal with something. And so, I mean, if I think in a slightly different way, we often talk, in ordinary human discourse about, gosh, I couldn't imagine what it'd be like to go through that. When you see somebody else going through some different, whatever it might be, grief and bereavement or whatever it might be. It's when you're in those circumstances that, you learn things about yourself, and it can be very difficult to kind of project yourself into those kinds of circumstances. And I think the requirement for every family and for every community to, in as much as they could, hold together and, as it were, get on with things, is what got people through.
Yeah. And the other thing, and again, I think we all nearly forget how remarkable it was the way that we all, right around the world, suddenly upended our daily lives, suddenly started living in a completely different way, suddenly started, living with emergency rules and social distancing and masking and all the rest. And obviously there's an element of self-preservation in that, but a lot of it was to keep others safe. There was a lot of social, so that the importance of that social solidarity in any crisis response, because it was remarkable what happened. And I remember government ministers at the time being afraid that people wouldn't actually put up with it, and being absolutely stunned that they did.
Yeah, and that's absolutely the case. And it touches absolutely on one, I think, of the really most important parts of resilience and preparedness, which I think we don't talk about enough. And for me, it's one of the lessons that comes from the pandemic and how we can protect ourselves and mitigate or prevent to the greatest extent possible. I think there's a risk that sometimes in thinking about resilience that we slip into the technical aspects of resilience, the institutional aspects of resilience. So we think about how we availability, if I'm thinking about things from a human health point of view, it might be access to medicines, it might be access to certain ICU facilities, things like that. They're all absolutely necessary. Nobody would argue that they're not necessary in terms of preparedness. But actually, what in societies that managed to get through, and I think ours was one, if you look at the public health indicators in terms of the outcomes, the experience in this country compares very favorably to other countries where comparisons are reasonable across Europe. By and large, the countries across Europe experienced this disease at, broadly speaking, similar timeframes. They had access to the same medicines, the same countermeasures of one kind or another, the same advice, the same data, etc., etc. But the responses in terms of outcomes were quite different. And in many ways, while there may be a degree of complexity to some of that, and population structures and all of that will have roles to play, clearly. But the extent to which there was resilience, community engagement, buy-in, a connection in terms of, let's say, decision making on the one hand, the decisions that people could see being made on their behalf at a political level, and the extent to which the public understood how well that was conformed with their understanding of the risks, all helped people to buy into the idea that we were all in this together. And I think that was something that was evident in this country. Of course, it's never going to be perfect, and over the long period of time that the pandemic played out, that was tested very substantially in every country. But I think in this country, people did, and I don't want to kind of trivialize it, there was a strong sense in which people collectively put on the green jersey. And that was part of it. And so that aspect of resilience about how well communities and individuals are literate and understand. And by literacy, I don't just mean having information. I mean having an ability to understand and to know why they're being asked to do certain things, to understand the connection between the evidence that's being seen and how it's being interpreted and the asks that are being made of them. We're not in a part of the world whereby we can compel people, as is the case in perhaps other parts of the world, to force people to do things against it. So public buy-in to the kinds of measures that will be required in the face of any form of emergency is critically important. And we need to put much more emphasis and time and effort into recognizing that in the way in which we build resilience, and not slip into the view that it's simply about technicalities or institutional capacity.
And it's not just about, NEFIT or National Emergency Crisis Groups. It feeds into, doesn't it, that point you were making about inequality. Because if people feel in a crisis that somehow we're all getting a fair shake here, then it's much easier to buy into the response, whether it's a health emergency or a climate emergency, whatever kind of emergency. That sense of fairness is critical, isn't it?
It is, and people can see that not only are they, so I think one of the things that arose here was that the vast majority of people bought into, and we had good data over a long period of time around opinions and from rolling surveys that were done and the attitudes that existed in society to the measures that were being asked. And there was a high degree of understanding and buy-in throughout most of the pandemic, as I say. For smaller numbers of people who didn't buy in, who were willfully not willing to follow, it was important then that others, the rest of the population, could see that there were measures in place that essentially helped to keep people safe. So for example, there were measures taken by the Gardaí from time to time. That was important, not just in terms of individuals who might transgress, but giving the sense to everybody else in the population who've understood, who've bought in, that their safety is being provided for through these measures. So we didn't police ourselves into this, but it was important for that sense of security, and that sense of solidarity, and that sense of us all being in it together.
Yes, and you know, we saw in various controversies, there's no need to go through them all, but the sense of outrage when anyone felt that fairness, if you like, was being challenged or not followed by people in authority. In terms of, if you like, the technical and institutional response, given that, you know, fairness, inequality, social response, that's a huge part of resilience in any political body, in any nation state or globally. But in terms of the technical side, what would you want to see done better next time?
If I think about some of our own lessons, definitely from my own point of view, I didn't understand the extent to which, for example, our colleagues, I now know it, in the world of veterinary epidemiology, have a much better handle on transmission and issues around transmission. And we could tap into that expertise at a much more at a much earlier stage. And it's one of the things that, you know, I take with me, not the only thing that take me into the work that I now do in the university, this idea of One Health and the need to break down these silos.
Because of spillover?
Well, yes, not just because of spillover, but like they have that developed expertise because they deal with, essentially the world of veterinary medicine is concerned about populations. They're herds. They live the world as opposed to individuals. The world of human medicine has become very focused on individuals and much less so on populations. So actually, the experts in managing population health dynamics are often in the world of veterinary medicine. Now, you would not have heard me saying that 5 years ago. I wouldn't have even understood it in that way. I've been reminded on it on many occasions by colleagues in veterinary medicine, and I've heard the word anthropocentric more times than I care to remember in the last couple of years since I've been dealing more with people in that world. But it's just reminded me that no matter how important an individual discipline might be or an individual expertise might be, none of them on their own is capable of solving almost any issue. I mean, it's a rare issue indeed that can be dealt with in its entirety from beginning to end by one expertise. And I can say that with some degree of authority coming from a profession that sometimes has that degree of professional hubris about its own value and impact.
And of course, one of the big challenges was the need to protect the healthcare system at a time when, you know, huge parts of hospitals' operations had to be diverted to the public health crisis, to the vaccination program, contact tracing, and all of that. Again, your thoughts about how that might be done better in future?
I think that's definitely one of the lessons that we have to learn. One of the principles, if you like, of emergency public health management is that in situations where there's a threat to general public health, you must focus on maintaining the health and well-being of the health workforce and keep them in post for very obvious reasons, because the public needs them. So it's an important tenet of public health protection. We found ourselves in a situation, the real challenge with COVID in every country was having to do tasks that in themselves weren't technically complex at a scale that we've never had to experience, certainly not in our lifetimes. So we were having to stand up very significant capacities for contact tracing, for swabbing, for vaccination when vaccines came along, for basic infection prevention control, and all of those measures. And we had to redeploy significant numbers of staff within the health service with substantial qualifications, providing services that were needed in society, and to switch off, as it were, those kinds of services. So if we're going to talk in terms of resilience for the future, one of the things we can do is build some of this capacity as part of an extended literacy into our populations, an ability to be able to respond and stand up capacities to provide what are relatively straightforward tasks within a system of clinical governance that could be deployed at scale if it was needed. So something along those lines.
A healthcare civil defence.
Well, yeah, I mean, that could stand up. I sometimes think about the census enumerators and that kind of, you know, every 5 and then certainly every 10 years, they just seem to pop up and they're walking down every street when they're needed. And there's that latent capacity within a population to respond in a particular way when it's needed. We could easily develop that kind of curriculum, that system of accreditation and oversight, and build a system of clinical governance that actually had that as the mainstay of provision, albeit on the appropriate supervision and so on and so forth, as would be necessary. But that would give much greater protection. And so it make that point in the context of developed countries like ourselves that have extent, for countries that don't have any healthcare workforce to talk about redeploying, it's the means through which their communities can respond. And so starting to see that kind of almost one, I would say now, a one health literacy, an ability to be able to move from human to animal to environmental issues within communities and have a cadre of people who can respond. In a way, it's the way rural Ireland used to be once upon a time, people who were literate in terms of health, of animals, of the communities and of their families, and building that kind of capacity back in. That's one I think really important.
And this would be done through something like the World Health Organization or the UN or programs like that, similar programs.
Where the mandate could come from, but I think the basic work of developing the curricula and so on are things that we're interested in trying to lead on in the university. So that's some of the things that we're working on at the moment in UCD.
In a future pandemic, because there will be another pandemic at some point, and we're not mentioning the H word here. In a future pandemic, would it be possible, do you think, say something as virulent as COVID, would it be possible with what we've learned to keep hospitals doing more of their general work than we were able to do in the early 20s? Or is that just too what if?
Well, there is a little what if. I mean, the reality, this is a respiratory viral agent. Nobody knows what the next agent is going to be. It is more likely than not to be a respiratory viral infection, but there's planning around syndrome or disease X, something that's completely unknown. So some of the international preparations have focused on that to think about that, those very broad scenarios. So there will be something around the peculiarities of an individual infection and how easily it is transmitted. The reality is that COVID was transmitted quite easily in relative terms in comparison to other infections, even the ordinary flu that we see. In the environments of acute hospitals where people are very vulnerable, where there's intimate engagement and so on, it can be very challenging to separate those two things. But a lot of lessons have been learned about infection prevention control. One of the things, again, not to be enumerating all the lessons that I think are there to be learned, definitely one of them that I think is important is that things like infection prevention control, things like occupational health were and then public health, I would also say, I would pick out as three disciplines that were underdeveloped in terms of the priority that's given to them. And the consequence of that then is like when we have poor infection prevention control standards in hospitals with poor hand hygiene and so on, that creates transmission risks in hospital environments. And it might surprise people to understand, the extent to which there is full compliance or not, even in the most high risk situations in big teaching hospitals. Again, not a problem that I'm identifying as connected only to Ireland. Occupational health services, which are there in the first instance to look after, to protect and to prevent illness among our healthcare workforce. We need to invest much more in the development of those kinds of, what might be for many people seen as kind of back office type services. They're not the services that you will meet as a patient going into a hospital, but in the complex world of modern healthcare, they're every bit as essential as every other service.
The other area where I think there's been a lot of discussion around the impact and how we might do things differently in future is the area of education, the fact that children and young people lost a couple of years of in-person education. And there's a lot of data around the world about the long-term impact that can have, and people will have various experiences of it themselves. Just your own thoughts on that. And again, there's a what if about it, but should we try harder to keep schools and education institutions running some kind of in-person contact in any future similar crisis?
I mean, I think in any crisis, a basic principle is that you want to minimize the impact of any sector of the society. So I think as a principle, of course, that would be perfectly reasonable to try to do everything that one can. In the context of the COVID pandemic, obviously there were recommendations here in other countries around school closures. Schools were closed for extended periods of time here, not always because of the public health advice. Public health advice was given around the closure of schools. The reopening of them required negotiations and agreements with unions and so on and so forth. So, but you're absolutely right that we've seen very clearly the impact that has had on children. and we start to think about children and adolescents, we're talking about the sections of society that, in a way we're asked to almost take the burden of almost every measure, insofar as almost anything that was a relevant activity, and certainly any that were associated with any pleasure or enjoyment in life among younger people were closed and not available to them. Even the basic thing of interaction with friends.
I remember just on that, I remember one of the reopenings going down to Cork, and it was Halloween weekend, and anyhow, the streets were full of young ones who were going out, and this young student from UCC wearing half nothing in the freezing cold, absolutely gorgeous she was, and it was her first disco. And I remember just being bowled over, like she hadn't had that for a couple of years. Just the impact of that on somebody's development. It's a very small, minor example. Much more serious, of course, was the kids. Again, back to the point about inequality. The kids for whom a break from school meant a permanent break from education, and the impact of that on the future direction of their lives.
Yeah, no, absolutely. And you're absolutely right to say that then wasn't felt evenly. I mean, there were children who were living in environments where they didn't have access to green space, and they were in houses that didn't have gardens, and so on and so forth. So there were significant challenges, and we know that there was challenge then created in terms of risks to children who were in vulnerable situations through things like domestic violence and other forms of abuse and so on, that we understand much more clearly now. And I think all of this needs to be taken into account in terms of the learning, because there's no sense in which we or any society got everything right, and that we have to factor that into the planning for the future. But I think, as I said earlier on, and not to be reiterating the point, one of the most basic learnings is to identify the real vulnerabilities that place people at risk, and to begin to tackle those in, I don't want to be using warlike analogies, but in peacetime. Not in the midst of a pandemic, not to find ourselves in the same situation again.
There's another question I've been wondering about, and it relates to nursing homes. And again, not in terms of the various controversies there were at the time, but the fact that the model of care for most people in their later years now is to move into a congregated setting. The direction of travel has been that these are increasingly privately run, or big companies running these institutional areas of care, not just in terms of transmission of a virus, but they've also been the various RTE investigates and so on. So it's just in terms of, I suppose, from a One Health point of view, have we got the right model of care for older people? Should we be asking questions about the direction of travel?
No, is a short answer to that. There was a specific piece of work done during the pandemic, and then closer to the end, a more substantial review of nursing homes led by Cecily Kelleher and a small team that made a number of recommendations focused on trying to address this. But just to make the point, and I would have made this point during the course of the pandemic in press conferences and so on, if we set about designing a system of care to place people who are older at greater risk from this particular infection, we probably couldn't do a much better job than the system of care that we have in place for people in those situations. And again, this is not uniquely an Irish situation. We have a situation where we have a substantial amount of that care provided for in privately run small facilities that struggle to meet basic infection prevention control standards, in spite of the good work of HICWA and so on to try and raise those kinds of standards. That they are privately owned, they're increasingly being purchased by equity funds who flip them for profit within periods of time and then move on. There isn't the kind of investment in the kind of additional services that you would really want to. I kind of bring all this back to the individual. Like, what would you want for your mum or for your sister or for your daughter or whatever?
Or even myself.
You're a long way away from what's the answer to that question? Because the answer to that question is the right answer in terms of what we need as a society. So it can't be okay if it can't be okay for other people and not okay for us as individuals. So I think we have searching questions to answer as a society. And it's not just in terms of the model of there's something wrong with the existing model of nursing homes and the legislation, the policy around that. That's part of the answer, of course. But to think about the values of a society that we have and around where we deal with older people. Because I'm old enough to remember, and I've looked around briefly, there's a couple of people that have similar ages in the room who remember that Irish society worked in a very different way not that long ago, where the care of older people was a responsibility, not in the burdensome sense, taken on by families and by communities, because that was where people wanted to be cared for. I rather guess if the majority of people were asked in a meaningful way, where would they wish to be cared for? They would wish to be cared at home and to be supported. So I think the challenge then at a policy level for us as a society is to design the kind of system that can, insofar as possible, as much as possible, provide support to enable people to stay at home for as long as possible and to prevent that sort of inexorable slide into dependence on nothing other than institutionalized congregated settings. Because that's, again, as I say, not what most people would want. And it's easy for me to say that, and I understand that it's very challenging to do, and we can't just be sitting here wishing ourselves into a different form of society. But there are values at the heart of all of that. What role, what value do we place on older people, and how do we individually want to be cared for when we're older?
I don't want to get stuck on this, but just having been a carer, it's just with the economic model we have at the moment, it's just practically impossible. I know so many women who go through, and men, but an awful lot of women who go through the whole bit, working while rearing a family, and then just as you're getting that behind you, you're moving into caring for older parents and trying to do that and your job. It really is, it's great to have the values, but it's not actually, many people find themselves in situations where it's simply not stacking up. And I suppose that gets back to the issue then of community supports and public health supports on the ground in communities where people are. It's all a bit idyllic, but as part of the sláinte care, that is part of, if you like, the direction of travel, you would hope.
Yes, absolutely. And so that, there's maybe two levels of which I might just briefly comment on that. So yes, you're right in terms of the design of a future health and social care system, which is based around maintaining health in the first instance, empowering people to take control over and mind their own health and stop the sliding. It's that people will understand the kind of the shift left of the paradigm. We've designed an institutionally based system with high levels of expertise that almost requires people to become ill in the first instance. And that's our default response. It's an institutional one, which is driven very substantially by many factors, including stakeholder and institutional interests, and not necessarily interests in terms of public health and human health, community health, and those kinds of factors. So I think there are hard questions.
Health and medicine are sometimes two different things.
They're entirely different things. And we cannot make healthy societies by educating doctors and only providing healthcare services in the way we understand them. We need them absolutely, but they play a part in contributing to, and I think many people will understand perhaps in this room, there have been attempts to try to work out in quantitative terms how much of the health of a society is determined by the provision of formal healthcare in clinics and in hospitals and so on and so forth. And the estimates might be around 15%. I get the opportunity occasionally to lecture students in the master's program and ask the question out, and I get estimates of 70% and 80% and so on. But it's the basic things like the health and well-being of women of childbearing age. It's about access to clean water, safe housing, good employment, access to opportunity. These are the things that determine the differences between health and well-being within societies and between societies. And we have to focus on developing those. And maybe to link that to the second point that I was going to make is that the thing that I'm most interested in being involved in broad terms now, in terms of my own career and so on, is making some contribution to what I see as the concept of the well-being economy. And what that is about is the connections between the deeply ingrained ways in which our economies and societies function and how that connects to every dimension of well-being, whether we talk about that in the context of humans, the environment, animals, etc. Because the thing that you mentioned a moment ago, that care, and the value that is in the context of the care that you provided within the context of your own family, it doesn't exist in terms of the formal measurement of economic value because it's not part of the GDP described model of success. We talk in this country and most developed countries about success has been equivalent to year-on-year growth, additional, when we all know that's not sustainable and nowhere close to holistic in terms of describing the things that are really valuable in what happens in society, including the care of older people and the care of younger people and families.
Now, you say it was really key here in Ireland that, if you like, politics trusted the science, and that was part of the response here. But we all know, and it seems to have accelerated since COVID, the growth of, you just look at RFK and what's happening in terms of opposition to mRNA medical developments, potentially, breakthroughs in cancer and other diseases. They're turning their back on that research there. General hesitancy on vaccines increasing, measles appearing where it hadn't before. So there's also been an increase in people who don't trust the science, and increasingly there are political actors globally who are saying, yeah, you don't need to believe the science, and here are the simple solutions. So if it was really important then, and it's been eroding since, how does that feed into what do we do? What should we learn?
Well, you're absolutely right to say that issue of trust in information, trust in authority is being eroded. I make a distinction between the two things of misinformation and disinformation. It can be confusing for people to understand now what represents safety, where the risks are. You think about people thinking about making decisions for their children in terms of access to medicines or vaccines. People will now ask very reasonable questions because they're concerned about the health of their children. But though people who are willfully spreading disinformation, I think that's a substantial challenge. There are obviously political motivations behind it, clearly. And it's enabled, obviously, through access to social media. It's been identified by WHO as one of the global risks to health, the so-called global infodemic. What we do,
and it's fed as well in a lot of occasions, not just by bad actors, but by people who see it as part of a wellness kick, that almost a misunderstanding of the immune system as something, pure that needs to be protected from assault, rather than a muscle that needs to be exercised.
Yes, absolutely. And like any industry, I think we have to be careful of understanding the difference between what, for example, what science might support in terms of knowledge and what might be promoted on behalf of any particular industry. And I think that's one of the substantial challenges that arises here, because when I go back to literacy is not just telling people things, it's giving them the ability to understand and to sift through for themselves and to understand how to discriminate, if I can use that word, between sources of information that they can trust and those that they can't. And those of us who either have access to understanding or who are in positions of authority have got to redouble our efforts. We see we have agency, we have literacy ourselves. We have an absolute obligation to contribute to this. And I think we have to examine, all of us, collectively and individually, whether we do enough in response to all of this.
But many of the people who would, if you like, be sending very different messages to you in terms of public health, they'll say, do your own research. They'll say, we are just checking things out. We are just finding sources. And now we're in the era of AI, who knows what gobbledygook somebody might come across. So you want a more educated public, but a little learning can be a dangerous thing.
Yeah, no, absolutely. And obviously the challenge of AI, and that makes that much more difficult. I think in truth, none of us really knows how the balance of positive and negative will go in relation to that particular issue. Clearly, there are benefits that are there by way of potential. So I think in terms of human health and screening and all of that, there are enormous potential benefits that you can posit in terms of the application of artificial intelligence. It comes into the question of in whose hands, who will be the determinants of how these tools that have the potential to bring good, but also the potential to bring harm, who will be the people making these decisions. So we think about in a global context where there probably hasn't been a point in human history where, the concentration of power, money, influence, authority, and now add to that list information in the hands of so few on behalf of all of us. And then that few sitting outside of the norms of democratic accountability. And so that's something that should concern all of us. So I don't have the solution to that, to be honest. I don't think anybody has the single solution to it, but it does point to the importance of politics and redoubling our effort to say, well, politics does matter. You see the election of people in certain countries without naming countries and so on. It really does matter what the outcome of some of these is in terms of the impact that it has.
The other aspect of resilience in any crisis And you've had experience of this yourself. For anyone in any frontline position, whether they're an academic, a politician, public health official, the level of, if you're in a prominent position, the level of abuse, trolling, maybe even direct harassment, that's now part of the gig. That's now part of what anyone doing those kinds of jobs, particularly in a crisis, it's kind of baked in, and you have to be able to deal with. And that's a change too, isn't it? And that's something that people who are involved in these critical responses are going to have to be well prepared for.
Yeah, and it, you know, look, it goes with the territory. If you know, if you have a role that has a particular visibility, without going too much into my own experience, the vast majority of my own personal experience was positive. You know, ordinary, decent people who would, you know, I had some examples of exceptions. I had protests outside my own house, and so on during the course of on two separate occasions. My children had some things happening in social media and so on that disturbed them at the time, that were all connected. I had late night phone calls coming from the Gardaí got involved in, and so on and so forth. So, but it was minor and it was manageable. And the vast majority of the response, I think, was in public was, I think where people got rightly frustrated was when they saw people in positions of authority or responsibility not living up to. And it was something that I certainly behind the scenes always emphasized, our responsibility in leadership terms to be seen, to be following the messages ourselves. And I think that was important in terms of solidarity. I think the reality of the kind of environment we find ourselves in now, I think that people who are in public positions, we see this kind of erosion of standards in terms of how they're treated. I do genuinely worry about a situation in which, you know, our political system, anybody who goes into politics now, is effectively making themselves and their families public property to be accessed and to be used in any way at any time of somebody else's choosing. And for the vast majority of people, actually, that's not going to be a fair ask. And so it's going to influence the kinds of people that we have going into politics and so on at a time, in a way, when we need people going into politics for the right reasons more than we've ever done.
We were talking about this a little bit beforehand, but what we're May 2026, we've had a COVID pandemic, we've had the Russian war in Ukraine, we've had Israel's war on Gaza, we've had accelerating climate change year after year. The news is worse and worse and worse. We have now the war in the Middle East, the war on Iran, the Straits of Hormuz closed, and another energy shock and possible global recession coming down the tracks. I mean, even if somebody's doing okay in their own life and they're not one of the many millions directly affected, the cutting off in aid programs, the impact that's having in Africa and throughout the developing world, all of that, people's panic levels, background fear levels, that noise is quite high, isn't it? And it means, you know, you hear about a ship docking somewhere and there's been an outbreak of something. So as a public, are we more scared than we should be about the next potential threat?
I think we're right to be concerned, but we can't live our lives individually or collectively in a state of heightened concern. We have to, like, we go back to resilience, that ability to be able to get on with things. As I say, in kind of simple terms, it means that, like, no matter what's happening in the wider world, if there are children in the house, they still need to go to school, they need to put a uniform on, and so on. So I kind of think, you know, and I'm not trying to suggest in any sense that really you should be like me. I'm just telling you in my own personal life, you know, I was saying to Kira, my wife, at some stage after we'd been, I don't know for how many months, waking up and discussing what was in the newspapers about the latest ramblings of you know who, and then realizing, hang on a second, we can't live our lives like this. We've got to find that that's there, and we just have to find a way of kind of getting on. And I think that's true in general terms. So at some level, we're going to have to accept that there will those who are empowered and who are in authority will have to deal with certain things, and we'll have to entrust to them, because we can't all live our lives in a state of heightened awareness, and we have things that we need to get on with.
Do we underestimate the impact of climate change?
The climate emergency is here. We absolutely do. And again, I go back to my kind of One Health framing. Like, some of the best evidence we have for it is actually healthcare evidence. whether it's in the footprint of infectious diseases on at a global level, or things like antimicrobial resistance on a range of different issues. We know and we understand the temperature effects on things like stroke and on pregnancy and a range of different conditions. But if you bring it back from a human health point of view, you start to see how is it connected to. So it is both caused by and is the cause of conflict that then itself is leading to migration. It's driving migration. The conflicts are driving migration. It's leading to significant changes in the way energy and water is being distributed, and water will become the new disputed, beyond oil, if you like. And
Even if we wean ourselves off fossil fuels.
yeah, so we will have those challenges around the fairness of distribution between those who have and those who do not have, in terms of access to things like energy and water, and the connections between all of those and things like the biodiversity crisis that we're seeing. I mean, I've come into contact now with people who live in that world. They're some of the most, I used to say, the one person you should never end up beside at a dinner party is a virologist. But I now kind of say it's actually a biodiversity specialist, because it's even more scary. The world that we've created, and the systemic impact that that's having. That we need to trace these connections that are driving. If I come at it a slightly different way, I think of it like the human health. So I spent my career working in the health system, and came to a point of realization that really the health system is dealing with the downstream consequences of how our economy and our society is functioning, and the risks that that then brings. And that not everybody who works in the health system, but some of us need to become involved in the discussion about how we influence that wider set of interrelated risks, and start to engage across other sectors and other disciplines to try and build some level of literacy and understanding, and to generate a conversation that, quite frankly, isn't really happening about the interconnected nature of those risks. And I have a very simple example that I sometimes use of this kind of challenge and lack of understanding. You can, and I double checked this morning, you can go into a major supermarket in this city and you can buy a chicken for your Sunday dinner for $3.99 to feed a family of 4. Now, there's a cost there that's not being seen, that's not being revealed, that people don't fully understand, and I'm not in any sense criticizing people who don't have the choice but to be able to purchase food at that price. But the impact of that, in terms of whether it's farmers out of business, the power of supermarkets, whether it's the impact on the animals themselves, the animal health, whether it's the wider environmental health, whether it's the use of antimicrobials, or any of those issues that are probably sitting behind a cheap chicken being offered to you in that way. We need to make these realities much clearer in society, and have a much more honest conversation with ourselves about the true price, for example, of feeding ourselves in the way that we are, and the unsustainable nature of that. Particularly, I think we have a particular challenge in Ireland in relation to that, because we have substantial food insecurity. We talk about Ireland as being Ireland, the food island, but of the vast majority of food produced in this country, it's produced for export. Most of the growing that's done in this country is of plant materials for feeding to livestock. And most of the food that we consume in the country is being imported. We're highly vulnerable to international shocks and the supply chain fragility that we see in the context of what's playing out in Iran at the moment, when we're in a situation where the climate would offer us an opportunity to be able to grow most of our own food needs if we were able to create the kind of incentives and so on. So all of these things are interrelating with each other. And your question began with climate change, but they're substantially influenced by climate change, or driving climate change itself. And then we're left then with the consequences of that, both in human health terms, in terms of inequality in our societies, and the impact in the environment with nitrates in our rivers and so on.
I think that was a point worth making, because I think sometimes we forget about how that's interconnected in terms of crisis responses, unless, of course, there's been a big storm and a flooding, and so. But it is about joining all the dots. I want to go back before I open up to the floor, which I'll be doing in a couple of minutes, and there'll be roving mics. I want to go back to the cervical check controversy. And again, I don't want to rehash an awful lot of that. We'd have done a lot of interviews over the years on this. But I want to talk about the point that Dr. Gabriel Scally made in his final report about, I suppose, the attitudes So a lot of the recommendations have been put in place, but we had a system where, you know, clinicians weren't openly disclosing to women, where Vicky Phelan had to fight the state through the courts while terminally ill to get open disclosure and justice. And this accusation that we have a health system, that the HSE is overly defensive, risk averse. On the other hand, maybe a public attitude, a public misunderstanding that screening is not a diagnostic tool. And I want to talk about screening a little bit before we open to the floor. So your thoughts on that, first of all, in terms of cervical check and that point about openness. I know we've had the Patient Safety Act. Some people believe it didn't go far enough. So just your thoughts on, are we in a better place? Have we moved enough?
I think we're definitely in a better place insofar as a lot of the learnings that have been derived from Gabriel Scally's, and there was also the Royal College of Obstetricians and Gynecologists review, have been applied. And we did have a very high standard of cervical screening in this country, introduced in late 2008, 9, 10, that period, because of funding that Mary Harney secured at a time when there was no money available for anything. And it has improved substantially, and I think people can have confidence in it. And obviously now the technical modality behind the screening has changed to a substantial dependence on HPV screening, which is much more reliable and takes out all the challenges of human variation and all of that. And so I think we have a world standard of cervical screening in this country, as we do with our other screening programs. And that was a difficult and painful process for the women involved and for many of the practitioners and so on. There were many, many lessons. And it did reveal a number of things about the profession. To be fair to the individuals involved, when I'm talking about individuals, I'm talking about in particular the cohort of gynecologists, the extent to which there was, let's say, a well-organized design of a system was open to question. They weren't well enough involved in the design of that and so on. So there were many, many levels at which we can look back at all of that. I think what it reveals is something that I think is painful for the medical profession itself to accept, and is that perhaps we're not as open, and I'm saying we, I include myself in that generalization of the medical profession, as we should be, coming from a position of, you know, maybe too much of a sense of, you know, we can rely on things that we know inherently, because the reality is that when you think about healthcare sciences, you know, the sciences are not perfect. The technologies that derive from those sciences, none of them is perfect. The drugs, the other interventions that we use, none of them perfect. We deal with patients in high-risk situations where the information that's being used around isn't always as complete as we would like, and yet healthcare decisions have got to be made and so on. So there will always be risks that arise in terms of patients and patient care. And the world and the understanding of patient safety is much more evolved now over the last, certainly over the course of my career, when the seminal kind of work of To Err Is Human from about the year 2000 was the kind of, for many people, the beginning of that kind of new science, if you like, of patient safety. So things have transformed very substantially. But the journey that the medical professions had to come on from paternalism, the kind of model of, dare I say it, trust me, I'm a doctor, to one where actually people are being given a better understanding. Doctors are operating on the basis of having to be trustworthy, giving people information that they can trust, and then they know why they trust the information. That's the kind of relationship that we have to have with patients in the environment we're in. And I think that's been a journey for not just in this country. And I think it'll be to the benefit of the services. But are we where we need to be? Absolutely not. We have to legislate for the provision of open disclosure and put systems in place to monitor things that you could argue should be just second nature and routine in terms of practice. And the model of open disclosure, which is now being built, is one which will require by law certain things that are very high risk, so-called never events, to be reported, and then to promote the practice of let's say, reporting for the right reasons. But, you know, it's off the topic you're asking me about, but I have a strong personal view that our system of medical negligence in this country is very substantially at the heart of this, and the driver behind it, that sort of model of defensiveness, where there is genuine fear on the part of doctors and nurses and frontline practitioners that if they say something wrong in a situation, that things can they can create risk either for themselves or institution. The science and the evidence is very clear that if you engage with patients at that point at which things go wrong, and unfortunately it's for the reasons I said earlier, that does happen, and you're open and you're honest and you maintain trust, it actually improves outcomes. That evidence has been well established. But the understandable, well, maybe understandable human response can sometimes be to close down and to close ranks. And that actually creates much of the challenge that I think we've got in this country around disclosure.
And now we are in a situation where we have the HPV testing, which is much more reliable, but there are still questions, aren't there, about the value of public screening programs and the risk of overdiagnosis, particularly breast and prostate cancers. They've been two that have, where those questions have been raised.
No, absolutely. And I think like it's one of the key issues that in introducing a screening program, it's the application of a test simply to create a population, so to speak, where the prevalence of the thing that you're concerned about, the issue that you're concerned about, is higher risk than the general population. And then you bring those people through a diagnostic testing process. But the screening test itself is not diagnostic. And you said earlier on that that's not well understood in the public. That's not well understood in the medical profession. So the distinction between the performance of a screening test and how to evaluate it and assess it and explain it versus a diagnostic test. And people will still talk about screening tests and use language in describing them that essentially suggests that they believe they're diagnostic tests and they should be subject to that kind of. So the idea of the screening is it brings people through that process and said, well, here's a person who appears to be at high risk because this particular thing has shown up. They're brought through a diagnostic confirmation pathway. The problem then that you're identifying, when you're absolutely right, is that if you don't design this well enough and introduce it in circumstances where you can be certain that you're making a positive contribution to overall health, the risk is that in fact that you might end up overdiagnosing. And so there's a very careful evaluation that has to happen with any screening test, that you can do the test, you can identify the right population, they will take up the test in the right percentages.
That's the issue with bowel screening as well.
That's the big issue with the bowel screening. So you could make an argument that we're paying, and I'm not making an economic point now about the cost of it, but I'm just saying you have all of the costs in organizational terms of running a program, but maybe not the population benefits when you don't get your uptake up to the kinds of levels that it should be at. So that creates an existential challenge in terms of the value of screening within a population. But the particular issue then is to ensure that the balance of risk and benefit, because unfortunately in screening programs, some people will be overdiagnosed, some people will be misdiagnosed, some people will be mis-screened and identified, and so on. So you cannot have a screening program where you can prevent harm accruing to anybody. So, but what you have to be sure at the population level is that the balance of harm and benefit is in the positive. Now, if you're an individual who's harmed as a consequence of that, it'd be very hard for you to accept that kind of population, if you like, contract, so to speak. And I think in the environment that we're in, and I think in particular in Ireland, the kind of litigious environment that we're in, that becomes a very difficult existential risk for screening programs, where there's very low levels of tolerance for some of the predictable error that will occur at rates that in population terms might make sense, but at an individual level won't.
And for all the flaws, and as I say, the SCALI recommendations that have been implemented, the Irish screening cervical check programme, it compared favourably, didn't it, on an international level with other screening programmes in terms of misdiagnosis rates or whatever you would call it.
Yes, and so the Royal College of Obstetricians was brought in to essentially evaluate that particular question around the quality of the programme. And in terms of its performance, it was performing at a level that was comparable to all other screening programs across Europe. So we know the screening programme was performing well, but the level of legal...
And obviously 221 plus women felt differently, completely differently.
People are entitled to a view, but let's say there is a discordance, if you like, between the level of legal activity that we have around cervical screening and the true performance of the programme.
Before I go to the audience, and as I say, the mics, we have, where are the mics? We have mics there and there. So just put your hand up and we'll get the mics to you if you want to put any questions to Tony. Before I go to the floor, how big a decision was it not to run for president? I couldn't resist it, sorry.
It was a very easy decision. Somebody asked me, and
Are you even more glad now?
I am, and to be honest, I look at what happened, and I look at what happened to Jim Gavin, who's a perfectly reasonable man, who, by his own admission, something in his past that he wasn't proud of that he did, and so on and so forth. But like, who among us here can say that there's no such thing in our own pasts? And it was poured over and talked about in every pub and kitchen in the country and he's a perfectly decent public servant coming to express an interest in taking on an office for the right kinds of reasons, I think. I don't know him now, so I'm not, he made a very substantial contribution for those who were interested to the improvement of a game of Gaelic football, which was dying on its feet, and anybody who's interested in Gaelic football will know the truth of that. So he's somebody we could all be very proud of, and yet look at what happened to him. And I felt so much for his children. I can think about that video footage of his inauguration and seeing his kids and how proud they looked, and think what life must have been like for them in school, and it was awful. So absolutely, no, there was a small decision for me, and
I've asked one or two of those questions myself along the way, I have to confess. But anyways, Tony, I just want to say thank you. It's been an absolute pleasure to have this conversation with you over the past hour and a half. I think there's so many things that could be the subject of discourses in themselves and what we've been talking about tonight, but it is really important to talk about them. And I want to thank the Academy for having these discourses, because you're right about the lack of trust in science, lack of trust in the media, lack of trust in politicians, all of that. But without serious people having serious conversations about serious issues, when that stops, then we really are in trouble. So I think tonight has been that. I hope it's one you've all enjoyed. I certainly have. Thank you.
thank you, Áine. Thank you very much.